Ladies and gentlemen, I coined the term foraminoplasty back in 1990, but it's still not really fully understood. So thank you very much for the opportunity in this lovely city to present an overview in front of such a group of world leaders in minimally invasive spine surgery. This is likely to be a bit provocative, so sit tight. I believe that minimally invasive spine surgery is being led by the nose. We think it's enough to be minimizing incisions, but we are seemingly replicating treatment pathways in the form of interlaminar radical discectomy, fusions into spinal spaces, etc. Even transforaminal discectomy is focused on carrying out discectomy and not looking at the other targets in the foramen. And we're tending to replicate diagnostic myths, such as that back pain comes from the disc, that instability needs to be fused, that failed back surgery needs pain management. And all of this, of course, has evolved from anatomical studies, analysis of anaesthetized patients, and inert x-rays and scans. And foraminoplasty tends to raise questions about these concepts. So foraminoplasty is a clinical paradigm. It's not just an interventional procedure. It's based on aware state detection of pain sources and driven by this to provide aware state, guarded, specific treatment. So let us look at the foraminoplasty technique, the pain sources, the treatment algorithm, and some combination applications. So when you've located the level that you want to treat by means of spinal probing and discography, then you'll come across this. If you go in with a dilator straight into the disc, unless you're very experienced, you will cause bruising of that nerve. The pointer doesn't seem to sharp on this. So the facet joint is to the top left. The nerve runs from 3 to 7, and you can see it's well bound down by scar. And dilatation will bruise the nerve and unfortunately fails to free or mobilize the nerve. So the concept of the procedure is based upon mobilizing the nerve, removing scarring, removal of the superior foraminal ligament, removal of osteophytes, undercutting, discectomy when and where needed, annuloplasty, and the insertion of gel strips. So I use the laser for this because it's very accurate, side firing is safe, and I can see what I'm cutting away. And as you see, we go up here and then cut away the superior foraminal ligament. We can expose the nerve and then address the undercutting and go into the disc if necessary. So when that has been done, the safe working zone has been cleared, the nerve is cleared up to the superior foraminal ligament. The head of this patient, in all cases, is to the right. And the superior foraminal ligament is often inherent to the nerve and behaves like Madame la Guillotine. Yes, I'm not averse to taking out bits of disc, but I try to, wherever possible, carry out a herniectomy. You don't need to take all the disc out. You're making work for the next generation. So here we are with the superior foraminal ligament resected, epidural fat billowing through, and a pulsatile but obviously irritated nerve root, which has had the binding scar removed from it. And we inspect anterior to the nerve because often there are osteophytes digging into the front of the nerve. And sometimes you come across the I've always expected. And here is a radial tear orifice. We would treat that by annuloplasty and decompressing the radial tear. So it's important to get to the correct level and then to treat the correct pathologies. So we're all brought up to look at, say, an L4-5 disc protrusion causing L5 symptoms. But more often than not, the superior foraminal ligament may be contributing or causal, as may be the ascending facet joint. As the disc loses height, so you get the instability, the nerve becomes impacted upon by the apex of the facet joint, giving you symptoms of instability. And it produces tethering by reaction and repetitive bruising. Matters are made worse by the tethering between the nerve and the disc, the shoulder osteophytes, and the sheer redundancy of the disc, and further aggravated by radial tears and leaks. I'm not going to animate this, but that is a nerve that's been decompressed. It's on the left-hand side. I show it because if you touch the surface of the nerve, you'll reproduce the patient's back pain. If you prod the nerve deeply, you'll produce dermatonal pain. So therefore, this accounts for why, in many cases, back pain is not arising from the disc. So, in cases of lateral recess stenosis or foraminal stenosis, there's often a shoulder vertebral osteophyte. We can treat that by foraminoplasty. The superior foraminal ligament is impacting on the nerve and causing further scarring. And disc protrusions and extrusions, as we've seen very elegantly this morning, can be treated either by herniectomy, laser discectomy or endoscopic discectomy. And high-intensity zones can be treated by laser annuloplasty or the use of gel sticks, the purpose of which is to deter ongoing degeneration by restoring more normal acidity within the disc. And the best access for most of these problems in the foramen is transforaminally. So here's a case of failed cage fusion surgery. You'll see there that around the caged implants there's a great deal of activity, and at the L4-5 level there was lateral recess persistent stenosis. So we carried out a laser discectomy at L3-4 and L5-S1, cleared away the breakdown products, left the cages in situ, made sure we weren't firing the laser at the cages, and decompressed the 4-5 level in addition. In cases of multi-level disc degeneration, we've seen a variety of treatments this morning. Here, we carried out a laser discectomy at L2-3, a foraminoplasty at the L3-4 level, and gel sticks at 4-5 and 5-S1. And in cases of more pure lateral recess stenosis, like this, a foraminoplasty at the L4-5 level, and if you look carefully, you'll see that L3-4 is degenerating in its posterior elements, and that was treated with a laser discectomy and gel sticks because it was another contributor to his pain. So these are just a few of the sort of combination. How are you doing? Jolly good. I don't know if I forgot to look. I hope we saw some of those. These are just a few of the applications of combination foraminoplasty. So looking at the technique as an algorithm, we start with weight-bearing flexion extension, sitting and standing x-rays. Obviously there's the clinical examination and MRI scans. So that's common to everything that we all do. But then, before deciding what level needs to be treated, and knowing that the MRI scans can be directly misleading, we carry out foraminal probing, and where that's positive, carry out discography, and where there's a lot of overlap between the levels, then we use neurotherm electrostimulation at each level to further clarify which levels and how many need to be treated. So we treat them with a combination of foraminoplasty, laser discectomy, annuloplasty, and gel sticks. But importantly, this is followed up by quite an intense program of muscle balance physiotherapy, as we saw earlier today. Well, what about clinical outcomes? I'm just going to touch on this because it's been published, but basically we seek to reduce back pain, buttock pain, leg pain. It's no good just treating leg pain or back pain. It's not what the patient's really after. And so on the whole, we managed to achieve about an 80% success rate using the ossuary and pain management outcomes at 2 years. You can see that the complication rate is very much lower than the majority of conventional techniques. And our 10-year study shows that it's holding up fairly well at 69%. It's interesting, we've only had 9 infections, 7 dural tears in the combination of nearly 7,600 interventions. And so far, we're in our early experience with gel sticks. I put in 17, and the results so far are encouraging. But I'm using it differently to the prescribed method. I'm using it in cases where there is settlement, and I want to slow that down, or in cases where there's a high-intensity zone and no leak. So in terms of patient selection, it's useful in the treatment of disc protrusion and extrusion and sequestration, lateral stenosis, and axial stenosis at a less severe stage than those been shown, I think, by Jean d'Estaing. And we use it in spondylolytic spondylolisthesis, because all you need to do is to free up the exiting or descending nerve root, as you'll see there. And in cases of degenerate spondylosis or instability, we need to remove the facet joint impaction upon the nerve, and in failed back surgery, to mobilize the nerve and remove the scarring. And this allows us to treat patients who are aged and infirm with multi-level pathology, often with adult or degenerative scoliosis and or osteoporosis. So in terms of alternatives, it forms a useful first step and should diminish the number of, or the need for, microdiscectomy infusions and total disc replacements and interspinal spaces. So I believe that it has a huge scope for transforaminal minimally invasive surgery for surgeons in the future. It counters the correct nihilism of conventional surgery, provides a future platform for disc replacement in certain forms. As you see here, we were putting these in Holland, and stem cell reconstruction, and combining this with better instrumentation in the form of endoscopic robots. Thank you very much.